here to share a little bit of experience of transitioning from our, early stages of building an integrated care network in East Toronto to actually starting to live the values and mission and vision of a learning healthcare system. Our journey is quite a long one. We started in 2018, really just how do we come together as a group of partners dedicated to improving the health of a population. And I think that you saw many of um, the pieces of the learning health system talk about the population base, the community base. And we were doing really well at building partnerships and breaking down silos initially around our partnerships and really focused on our equity seeking populations in our priority neighborhoods in East Toronto. And in 2020, we made the conscientious decision to move towards a learning health system model and taking those 5 pieces of the learning health system. We thought we were doing pretty good at having data and making decisions based on some information and population-based data, doing evidence synthesis, not trying to reinvent the wheel, but learning what others have done and actually bringing it to bear in a sort of rapid cycle process, co-designing with partnerships from the community members at the decision-making tables. We thought we were doing a great job. And so we really felt that evaluation and implementation were our weakest links within that coordinated effort of a learning healthcare system. And so from 2000 to 2023, or sorry, 2020 to 2023, we really focused on capacity building. And what we were hearing from our partners within our integrated care system was that we really needed to build some evaluation capacity and capacity at the front end, at the sharp end of the healthcare system. And so we put on a series of workshops and we did a lot of coaching and co-design efforts around how do we build an integrated care system that had this hub and spoke model for evaluation. We had a centralized hub with an evaluator, a professional evaluator, PhD trained, who was that contractor, that general contractor that helped to set up evaluations. But really the diffuseness of how we collect data and use that information for improvement was left to the people at the front lines. And where we ended up is a lot of stories. We heard a lot of stories, and stories are fantastic for connecting the head to the heart, creating empathy, creating joy and meaning around your work. But what we found difficult is actually to connect that back to that value statement of the quadruple aim plus equity. And so our next vision was in 2023, we launched a portfolio that was going to be that contractor hub and spoke. That hub was now populated with some resources because our infrastructure was very, very lean. So having a single evaluation person was not enough. We needed to supply them with a project manager. So that project management part of implementation and taking things to scale was really key. We needed to provide them with those qualitative science experts because our PhD trained person was a data scientist. So we needed to complement their skill set with a qualitative scientist. We also needed to provide a little bit better access to data, which is probably our biggest barrier as we start to move forward collectively into this new accelerated OHT, really breaking down the silos and the barriers around data. We also learned a lot about culture, and I'm gonna, like, the cautionary tale for us was really around the culture. We found out after all of this wonderful capacity building and thinking we were doing a fantastic job around evaluation and capacity building, that evaluation, and anytime you brought evaluation up, it was really like a 4-letter word. It was one of those things that people didn't want to hear, didn't want to talk about. And it was really around the culture, and people were used to being evaluated. And if we were evaluating, we were looking at and evaluating them as individuals and not necessarily evaluating the program or the implementation. And so people had that connection of being evaluated, thinking that that brought us to the other F word, which is failure. And so they didn't want to know if we were failing or not. And I think as an implementation scientist and a patient partnered implementation scientist, we've learned that failure is important and quality improvement is about failing, learning what works, what doesn't work. And so our next big challenge was learning to normalize failure and really having a safe place to fail, to learn how we're going to fail fast so that these cycles are faster. And so we have built in some of the infrastructure and the support around failure. We have a community of practice around failure. And that failure now extends into it seems like a little weird thing to have a community practice around failure, but it gives people the opportunity to talk about the things that they're really struggling with. And so one of our big lessons learned was having that open community of practice that allows us to talk about things that aren't going well. As an implementation scientist, I'm like, we're failing. That's great. We can start to de-implement that, get that out, get the things that aren't working out. But that's really not what healthcare does, right? So this series of pilots that has been brought up, that's what healthcare does. We have a pilot, it keeps going, it might be in the background, it's not really working, but we're going to keep our resources to it. Where in a learning health system, you identify what's not working and either see if you can adapt it to fit to that local context, or you throw it out. You've learned, you learn it doesn't work, we have another fix, bring in another co-design session. And so that's really the beauty and the brilliance of a really robust learning healthcare system. And so our big goal for 2024 is actually to break down the silos of data. So we have data sitting in pockets at each organization within our Ontario healthcare team, and we don't talk to each other. We don't share data. Where I'm sitting in the hospital and we have terrible data on equity. Our community health partners in CHCs have fantastic data on equity and equity social risk factors. And what we're going to be doing is having a community of practice around data. And we are taking the research lens because research, you can get away with sharing data a little bit easier for whatever reasons, than trying to actually do it to share from a population perspective. So that's a little bit about our journey, where we've gone, where we're coming from, and where we see us going in the future.